Thank you so much, ma'am. And a big congratulations to the organizers for putting in such great topics, especially Dr. Archana. Okay, so perianal fistula. So there are few topics in MRI where the surgeon is sort of actually dependent upon us, and we should actually exploit this, right? So today's seminar would be under these outlines. I'll talk about relevant pelvic anatomy because I cannot go ahead until I give you a clear description of the pelvic anatomy. Then we'll talk about MRI protocols, show you some case examples, and end with reporting essentials, what you need to know. Right. So why MRI? It is non-invasive, non-radiation, multiplanar capabilities, and of course, very good soft tissue contrast and spatial resolution. Detailed knowledge of relevant pelvic anatomy. You can see sphincters and fistulas directly, and accuracy in classifying the fistula. Accuracy in knowing the tract better in terms what is the length of the fistula, where is the internal opening, where is the external opening, what is the activity, whether it is acute, subacute, chronic, branching or ramifications, or any associated abscess. Now, when I was a resident, I remember distinctly that we used to, see all kinds of perianal fistula, cannulate them with a scalpel set, trying to get a contrast inside, and then often these results would come that yes, there is a linear tract not communicating with the bowel. Now when I look back, I see most of these fistula, when I do on an MRI, they do communicate with the bowel. So we have come a long way, right? So this is the basic anatomy, right? So as you know, the anal canal is the portion of the GI which lies between the external and which lies on the sides by the external and the internal sphincter. So what is this external and the internal sphincter? So basically what happens is you have got the levator ani muscle. The levator ani muscle gets condensed into puborectalis, and the puborectalis further gets condensed into external sphincter muscle. And the internal sphincter is nothing but it is the circular muscle of the rectum, which continues in anal canal as the internal sphincter. Now, let us get an idea of the external and internal sphincter because this is the mainstay of your diagnosis, right? So this is a T1 weighted images with normal fat. So what you can see here, this bright signal is the intersphincteric fat. What you see here inside, so remember the internal sphincter would look hypo on T1 and would look hyper on T2 because these are circumferential muscles, while the external sphincter, which are actually sort of skeletal muscles, would look hypo on both T1 and T2, right? Of course, you need a T1 for the anatomy, and then you need a T2, especially T2 fat suppressed to see the fistula. So here the fat is suppressed, but you can see the difference in the internal and the external sphincter. And when you give contrast, very important, this because you know that there is circumferential muscles of the internal sphincter, they have more vascularity, they enhance better. So the red arrow shows the internal sphincter, and the hyperintense non-enhancing muscle, the circumferential muscle, is the external sphincter, right? The anatomy better seen on a coronal with the hyperintense enhancing internal sphincter, and then on the outside you have got the external sphincter. Also remember, very important is the levator ani muscles, which you need to see on a good coronal. Right. What is the pathophysiology of perianal fistula? By definition, perianal fistula is an abnormal connection between the epithelialized surface of the anal canal and the skin. The most of the causes are primary. What happens is there is an infection of the anal gland, right? Then due to the impaired drainage of the anal gland, it forms a perianal abscess. It ruptures, and the space it gets usually is the intersphincteric space, and from the intersphincteric space it goes in many directions, in the external sphincter, in the internal sphincter, and you can have various tracts. Secondary causes consist of 10% of other disease like Crohn's, tuberculosis, pelvic infection, radiation, etc. Right. What is the epidemiology? Males usually more than females, age group 20 to 60. Intersphincteric tracts are more common than extrasphincteric tracts, then transsphincteric, unilateral common, then bilateral. And you have side branches, abscess, combination, and permutations. I will show you cases for that. Right. What is the protocol? First thing is you keep a marker at the site of the discharge so that you know where is your external opening. You can keep a vitamin E capsule or anything like that. Then what you do is you take axial oblique and coronal oblique. That means you take a sagittal first, and then you take sections perpendicular and parallel to the anal canal. So it becomes oblique because the anal canal is not absolutely straight. So you take both T1 and T2, both with fat and without fat. Remember, the fat is a friend of yours in this case, because you want to see the intersphincteric space, which is fat. And then very important, you have to take the 3D or the volume images of the post contrast with very less of slice thickness and maybe zero gapping, because you will be able to see very small and thin fistulas. Diffusion weighted is an optional thing, though we do it routinely, right? So here you see two images. So one, you see this is without fat set, right? So you can see the anatomy better. And then this is a with fat set where you can see the fistula better. So for anatomy, you need with fat, and to see the fistula, you need fat suppression, right? So this is a case where we have used diffusion weighted imaging, and you can see what happens is, because diffusion weighted basically behaves like a heavily T2 weighted images. So if you have a very, very small perianal fistula, they will be seen as bright spot on diffusion. And if they're of acute etiology, they will show restriction on your ADC. Right. So surgical classification and radiological classification. So the classification of perianal fistula started with the surgeon's classification, the Parkes classification, which divides it into intersphincteric, transsphincteric, and suprasphincteric and extrasphincteric. So this was the classification which started. Even today, some of the surgeons want this classification, though this was the classification which is now widely accepted, the radiological classification, which is the St. James University Hospital classification, which is similar to Parkes classification, only that it has in addition complications like abscess and secondary tract, starting from grade 1 to grade 5. Grade 5 is when there is involvement of levator, supra and translevator. So doesn't make a difference you are giving Parkes classification, or you give St. James classification, or you give no classification. The way I report, I usually do not give classification. What I do is I give all the relevant information. That is what your surgeon needs. Now there is a template for it. You do the reporting in that template, give them all the information, and they are happy. Right. So you know the anal clock, right? Very important. So you have to tell the opening whether it be external or internal in terms of anal clock, right? Very easy. Anteriorly, you've got 12 o'clock. Posteriorly, you've got 6 o'clock. Left is 3, right is 9 o'clock. So whether external or internal, you have to give this anal clock. What is the MR appearance of perianal fistula? So it would be iso-intense or hypo-intense on T1. Of course, if there is some hemorrhage, it would be hyper-intense on T1. But T1 is usually not a very good sequence to look for the fistulas. It is the T2 sequence, especially the fat set sequence, which is the ideal sequence to look for fistulas. They will show peripheral enhancement on contrast administration, especially if they're acute, and that is what most cases would be. The common shapes could be linear, curvilinear, horseshoe shape, and of course, you will have associated abscess, which will show peripheral enhancement and restriction on diffusion weighted images. Right. So this is the mainstay. You have to give information which is very essential. Now we are slowly moving from didactic reports to structured report. The surgeon doesn't want a full page of paragraph, the study shows evidence of one blah blah blah. No, you just give them what they want. You give them the external opening, you give them the internal opening, you give them the length of the tract, the nature of the tract, whether there is ramification or not, whether there is associated abscess or not, what is the distance of the internal opening from the anal verge, right? Whether the tract is infralevator, supralevator, whether it is involving other organs, and he is happy. Right. So let us see some case examples. Okay. Starting with a simple case. So see, you've got your external sphincter, you've got an internal sphincter, and what you have here is a simple intersphincteric fistula. So I'm representing this on a diagram. So this red muscle here is the external sphincter. The green muscle here is the internal sphincter. Between them in the intersphincteric space, you can see the fistula. So a simple intersphincteric fistula, and the fistula goes down and opens externally. This is the simplest type of simple linear intersphincteric fistula. Second case. Sorry. Yeah. So you've got again one more fistula lying in the intersphincteric space, right? The internal sphincter, the external sphincter, right? You go ahead and see there are actually two fistulas, both of them lie in the intersphincteric fistula. There's an internal opening here, the red arrow, right? And then both of them are on the sides, but they do not communicate with each other. They are not making a horseshoe, but then both of these are simple intersphincteric fistulas. Third case, the intersphincteric fistula becoming an abscess. So you've got an intersphincteric fistula, but this time the fistula is getting distended, filled with fluid, and you can see a full abscess inside the intersphincteric space, right? You can see this abscess, right? So an abscess with the intersphincteric fistula. What do we have here? Two abscess-like tracts. So two widened tracts, again lying in the intersphincteric space. This is the axial image. You can see them even in coronal, right? Bounded by the external sphincter on the outside, by the internal sphincter on the inside, and between the two lies two abscess-like tracts, which again merge and then open externally, seen well on the drawing. Okay, so after intersphincteric fistula, which are the most common, coming to extrasphincteric, which is the second most common type. So here you can see there is a large tract which is almost becoming an abscess, and it goes. So you can see the sphincter is somewhere here. It goes and crosses the levator and opens actually into the rectum. So this is an extrasphincteric fistula which runs through the levator ani, and there is actually an abscess-like thing in the left ischoanal fossa. It is above the sphincter complex, and therefore it is extrasphincteric. Again, more examples of extrasphincteric fistulas. You can see multiple extrasphincteric fistula, right? All of them right and left, more on the left than right, and then all of them opening inside. So more ramifications and more extrasphincteric fistulas. Then it becomes a bit more complex. Here you have a case where there is an extrasphincteric fistula, a abscess, and a ramification. Okay, so this here, the yellow arrow here, shows the extrasphincteric fistula. Apart from that, the orange arrow shows an abscess, and then there's one more tract. If you can see this horizontal tract coming out here, the white arrow. So you have got a fistula, then you've got an abscess, and then you've got a ramification. So you need to tell everything in your report that there is an extrasphincteric tract, there is an abscess formation, and then there is a ramification arising from it. Okay, one more case of extrasphincteric abscess where you can see the abscess is so extensive that is almost involving the whole of external and internal sphincter. You can see well on the diffusion weighted and the ADC. So actually there is sphincter destruction, a very severe case of abscess. Then the rarer transsphincteric fistula, again a simple linear tract. See how it crosses the fistula. It is going through and through internal and external fistula with an internal opening inside at 1 o'clock position. So this is a case of simple transsphincteric fistula with the opening at 1 o'clock, going through and through the internal sphincters, through the external sphincters, and opening outside. Right. Again, now a simple case of intersphincteric fistula. Here you can see the fistula, external opening 6 o'clock, going, and just opening, right? So simple linear tract, small tract with both opening external and internal at 6 o'clock. What do we have here? Grade 2 intersphincteric fistula. There is one fistula which arises, goes, then you see another fistula arising. So it's very common to see multiple fistulas. The first fistula ends at 12 o'clock internal. The second one is continuing. The second one now ends at 6 o'clock. And both of them are communicating with each other, giving a horseshoe type of fistula. Another case, extrasphincteric fistula. The fistula arises, becomes almost like an abscess running, and then where does it end? It ends in the levator ani, right? This is the levator ani muscles of both sides. You can see the fibers involved by this abscess. So once the fibers of levator ani are involved by the abscess, it becomes a grade 5. So one common question is asked, when should you call it an abscess? When should you call a fistulous tract? So what the literature says is 1.5 centimeters or 15 mm. Anything more than 15 mm becomes an abscess. Anything less than 15 mm becomes a tract. Right. Then you can have complex fistulas like these, two external openings in the left side perianal region, combining together, making one fistulous tract, going ahead. It goes, right, goes into the intersphincteric space, then again divides into two parts, one of them opening at 1 o'clock, the other not opening at all, becoming a sinus tract. Yeah. Okay. One more complex case, transsphincteric and extrasphincteric tract with supralevator extension. Okay, so actually sometimes the fistulas are so complex, the way they ramify, it becomes difficult, but you have to pay attention. Okay, On the right side, what do you have? You have an extrasphincteric thick tract, right? And then it sort of curves, crosses, perforates both these sphincters and becomes transsphincteric. So there is an extrasphincteric tract which becomes transsphincteric. What happens on the left side? On the left side, you see an abscess, a large abscess in the supralevator region, right? This is the levator ani. Above that, the supralevator, it crosses the levator and then it opens inside, right? So on the left side, you again have an extrasphincteric tract with supralevator extension and abscess, a grade 5 complicated tract with ramification and abscess. Right. So supralevator extension is something which you need to mention in your report. Even if there is no supralevator extension, you need to write that there is no supralevator extension, because once the levator ani is involved, the treatment is different. It has a bad prognosis and it would involve more surgical intervention. Right. So a simple case of an abscess in the ischioanal fossa. Sometimes you'll just see abscess in the ischioanal and the ischiorectal fossa. Proctitis, you might not see any fistula or sinus. You might just see inflammation and thickening of the rectal wall. So proctitis. Okay, this was an interesting case. This was a lady with Crohn's disease, right? And there was actually nothing else other than this very small tract, which actually was not very clear on the T2. But when we did a post contrast, we could see a tract. And look, this tract, what is doing? It is going inferiorly, posteriorly, and it is actually opening into the vagina. So this is a transsphincteric fistula with vaginal extension. Similar case in male, there is a tract which is actually going anteriorly to the root of the penis and it is opening into the urethra. So there is a periurethral communication you can see, right? So these kinds of communication are very important. You need to tell them in your report. Perianal sinus. So a lot of times you will see that there is just an external opening and there is no communication. There is no internal opening, right? It just runs, but it ends blindly, neither the muscles or the fossa fat, right? Like this, or an abscess just in the near the external opening, not running anywhere. So two cases, one of a perianal sinus, one of an abscess. However, in my experience, we are also having a thesis on this. We have seen that a lot of cases we just call perianal sinuses, when they are operated, actually they turn out to be fistula. So actually it becomes an issue when the tract is occluded. They do not have a very obvious internal opening. The internal opening is occluded. Then yes, you can miss at times. Okay, sinus, pilonidal sinus, it is a type of sinus due to hair follicle infection, where you can see a tract which just rises at the back at the gluteal region and ends blindly in the soft tissue of the gluteal region. So pilonidal sinus is again an important entity which comes. Seton is something which has been done from very long time, which is basically what they do is the surgeons put in a rubber ligature, right? Which this seton, remember, will seem hypointense on all sequences, and you need to really tell about the location of the seton. So what they do is they keep the seton and then they tighten it every 2 weeks or so in order to have some pressure necrosis, so that the sealant, when it is pulled slowly through the muscles, it cuts and fibroses in order to cause little damage but causes healing at the same time. So reporting checklist, what do you have to say? You have to tell them about the type of fistula, right? What type of fistula it is. Second, how many branches it has, the length of all the tract, the branches, the external opening, the internal opening, whether it is infralevator, supralevator, right? The distance of the internal opening from the anal verge, the width of the tract, any associated abscess, involvement of any other organ, if it is involved, right? So these are the reporting templates. You will find the commonly used reporting template are that of ESGAR, the European Society of Gastroabdominal Radiology, and the American Society of Abdominal Radiology. You can use something like this. If you run out of template, you can just write the things as I do and just make a small line diagram telling your surgeon where exactly the sphincters are, and that helps a lot. Concluding, MR fistulography is imaging modality of choice. We've come a long way from conventional to MR. MR helps in accurate delineation of primary and secondary fistulous tracts and their anatomical extent. Perineal fistulas may have complex appearances, may not follow the classification. MRI is a valuable tool enabling radiologists to roadmap fistulous tracts and identify associated complications, helping in preoperative surgical planning and favorable outcome. Thank you.